Hello, I'm Balázs Komoróczy, and I would like to present my 9-month progress report on my PhD topic, which is screening and prevention of adverse pregnancy outcomes in Hungarian population. As an obstetrician and as a PhD student, my vision is to prevent adverse pregnancy outcomes such as preeclampsia or preterm birth. And as a mission, I would like to develop a reliable screening model for pregnancy complications leading to preterm birth. For this, we are investigating two slightly different but still connecting topics. In my first topic, we are examining low-dose aspirin prophylaxis during the pregnancy, which seems to prevent preeclampsia and improves fetal outcomes. Just a quick recap of the background. The incidence of preeclampsia, which you might know can be a life-threatening pregnancy-related condition, is approximately 5%. It is well known and it is well studied that low-dose aspirin reduces the frequency of preeclampsia. But however, the optimal dose of low-dose aspirin is still not defined. Our aim by the study is to investigate the safety and efficacy of different low-dose aspirin prophylaxis during pregnancy. To answer this question, we examined as many pregnant patients as we could, and regardless to the risk of preeclampsia. So we are investigating patients with different doses of low-dose aspirin compared to placebo, and we examined 8 different outcomes, what I will show you later. Our hypothesis was that 80 mg aspirin is the optimal dose for preventing preeclampsia and adverse pregnancy outcomes. We set up a search key on the 3rd of November 2021, and by this search key we conducted a systematic search. And after the flowchart, after the selection, you can see the flowchart. We had 62 eligible full text for the analysis. Here are the outcomes what I will talk about. As you can see, we did the analysis if all the studies were involved. We did the analysis if the aspirin prophylaxis was started before the 20th week or was started after the 20th week. And for all the outcomes, we did an overall and subgroup analysis. Overall analysis is to answer the fundamental question, is aspirin protective against the outcomes? And subgroup analysis is to answer the critical question, which is the best and optimal dose of low-dose aspirin. In these 3 outcomes, preterm birth, placental abruption, and neonatal intensive care admission, we did not have any significant effect of low-dose aspirin, which can be considered as good. I mean, one of the most concerning contrasts against low-dose aspirin is placental abruption and fetal and maternal bleeding, such as for the neonates is intracranial hemorrhage, which usually has to be for which the infant usually has to be admitted to an intensive care unit. But these were no significant differences. The significant differences were mostly in the cases when the aspirin was started before the 20th week. For preeclampsia, just a few sentences about the following slides. In this first line, you can see the overall risk ratio and confidence intervals. And below this, in the lighter boxes, you will see the subgroup analysis with each milligrams and each risk ratios and confidence intervals. For preeclampsia, it seems to be aspirin protection is protective against preeclampsia, and in the milligrams of 75 milligrams and 80 milligrams, it has a significant effect. I will talk about later because for preeclampsia, we also conducted a dose response assessment. But let me guide you through the other outcomes. For this analysis, we had 46 articles. For intrauterine growth restriction, aspirin seemed to be protective overall if it was started at any time in the pregnancy. There is it will be harder to define a dose-response meta-analysis because, as you can see, 75 milligrams and 150 milligrams seem to be significantly effective against intrauterine growth restriction. I have to say that intrauterine growth restriction can be accompanied with preeclampsia, and these studies did not separate them. For gestational age and for birth weight, we had also significant difference with the mean difference of 0.30, which means more than 2 days in days. It's in weeks, but it means more than 2 days. 100 milligrams of aspirin seemed to be the most effective, but overall it has a significant difference in favoring the aspirin groups. For birth weight, the mean difference was 65 grams. The differences between the two groups, and also 100 milligrams seemed to be effective for the most. And if I have only one chance to mention that any avoidable perinatal death is the most important in these cases, I think, and it's really nice that we can see that with aspirin prophylaxis, the perinatal, neonatal death, and stillbirth as well together can be avoided in cases. For this analysis, 81 milligrams seem to be the most effective. Just to sum up, so with aspirin prophylaxis, if we treat 1,000 women with aspirin, 10 fewer cases in proteinuric preeclampsia, 9 fewer cases in intrauterine growth restriction, and 5 fewer cases in perinatal deaths. We have a non-significant outcomes as well. Preterm birth, 11 fewer cases per 1,000 treated women. As I said before, for preeclampsia, we did the dose-response meta-analysis, and with this log linear correlation, we found that every 25 milligram increase in aspirin dose was associated with a significant 7.2% decrease in the risk of preeclampsia. So as a strength is the first dose-response assessment, but as a limitation, it's not a classical dose-response because it would require more doses in each article, and we cannot fit in this rule. We have huge sample size, but we have heterogeneous population, and sometimes the outcome measurement definitions differ in each group. But as a conclusion, I would like to say if a patient in high risk, aspirin should be started. And for all the benefits, at least 100 milligram aspirin is indicated in high risk pregnancies. Our second topic is screening for spontaneous preterm births in singleton pregnancies. The incidence of preterm births is nearly 12%. Screening for preterm births is one of the most studied challenges in obstetrics. And it seems that combined screening model of cervical length and obstetric history for prediction of preterm birth seems to be the best. Our aim with this study, we would like to translate cervical assessment into a better clinical practice in the Hungarian population by assessing the maternal history as well. And to answer our clinical question, how does a shortened cervix measured at the second trimester ultrasound screening affect pregnancy outcomes in our population? And how maternal and medical and behavioral history affect these outcomes? We will examine pregnant women with singleton pregnancies, and we will compare shortened cervix to normal cervical length. And as a primary outcome, we will examine preterm birth. Our hypothesis is that the incidence of preterm births won't be affected by medical and behavioral maternal history. We would like to include as many patients as we can, and we will drive them into two groups: the group with normal cervical length and the group with shortened cervical length. And we will assess the following outcomes, but primarily the incidence of spontaneous preterm birth. Just a quick recap. We would like to submit our first paper in August of this year, and we would like to start the patient enrollment for our second study in September. Thank you for your attention, and as a closing remarks, I would like to say that if you are working on something that you really care about, you don't have to be pushed, the vision pulls you. Thank you.
Congratulations on your work. So I would have a question regarding your first project about the regular aspirin taking during pregnancy. Should I have any concern regarding the earlier closure of the ductus arteriosus, especially if I start to take aspirin regularly in the third trimester?
Yes. Thank you for your question, first of all. And my answer is yes. It is a well-known side effect of aspirin that it can closure the ductus arteriosus. That's why most of the studies discontinue the taking of aspirin in the 32nd or in the 36th week of the pregnancy, but it is also seen to be safety if we use low dose aspirin, and low dose aspirin is not well defined, but it's under 150 milligrams of aspirin. So there are a lot of studies examining this as well, and a lot of studies examining aspirin intake until the delivery, and there are no significant harms has been shown in these studies as well.
Okay, thank you.
Thank you.
Great presentation. My name is Faris Mazinic. I'm coming from Slovenia. Just one question about your meta-analysis about aspirin. There were many meta-analyses about aspirin and effect on perinatal outcomes. And aspirin was here for this purpose from 1979. There was publications about the effectiveness. But only in 2016 there was just one randomized control studies that showed a great effect of aspirin, and that was the beginning of systematic use of aspirin. I noticed that you had a lot of papers included in this meta-analysis, but actually the effect of aspirin is shown just in this randomized control study for Fetal Medicine Foundation. And I was wondering, what was your criteria for evaluating the specific points or specific dosages of aspirin? Because there's one question about population, because the population was very, very important in terms of pregnant women that had screening for flow in uterine artery with Doppler in 12 weeks, and aspirin should start before 16 weeks of pregnancy to have effect. What was your experience or data that showed about that? Thank you.
Thank you for your question. It's a really good question, and it's a really good question we have to think about, because in this study, as I said earlier, we wanted to involve as many patients as we can, but we did subgroup analysis, but I did not have the time and did not have the opportunity to show this. But yes, we did analysis about different inclusion criteria, if the inclusion criteria fit in the NICE criteria, or if the FMF criteria, or the uterine artery, abnormal notch on the uterine artery, and for these, the statistical analyses are still ongoing. I won't be able to answer this question properly, but yes, it's known, and we are doing analysis for this too. And I'm sorry, but I won't be able to answer that question right now in this status of our study.